We've got one of the highest incidence of keratoconus in the world. The current official stance on this is that 1 in 100 people in Australia will have keratoconus or currently have keratoconus. There are some studies showing that that prevalence is higher, so it's about 1 in 87 in Tasmania in particular. So we've got, in a study that hasn't really been published yet, but I've seen some data on it.
Do you rub your eyes because they're irritated? What if I told you that you could be causing long-term harm to your vision by doing so? Today, I'm pleased to be speaking again with Martin Robinson, an experienced optometrist and the current president of the Cornea and Contact Lens Society of Australia. Martin leads Martin's Eye Care in Tasmania, where he and his team provide thorough and personalised care to their community. In this conversation, we're talking about keratoconus, a condition that affects the shape of the cornea and can have a big impact on vision. It's not a well-known term to most people, but understanding it can make a real difference, especially when it comes to early detection and treatment options. Over the next 30 to 40 minutes, we'll cover who it tends to affect, how it's assessed, and both non-surgical and surgical management approaches that are available today. If you've recently been diagnosed, know someone who has, or just want to better understand eye health, this discussion's for you. But first, who am I? My name is Paul Salloway. I'm the owner of Optics Digital Marketing. We're an agency that helps independent optometrists to grow their practice. So, hi Martin, good to see you again.
Thanks very much, Matt. Thanks for the introduction.
You know, keratoconus is a condition that affects the cornea, so who better to speak to about it than the president of the Cornea and Contact Lens Society of Australia, so you're well versed.
Thank you. Yep. I think your opening comment about eye rubbing is something that I would imagine virtually every Australian has done at some point in their childhood. You know, whether they're crying and they're rubbing their eyes or they've something in their eye, got an allergy. And it's something we do from childhood without any thought of what we're doing, really. And I saw a video a while ago, and it was an MRI of someone rubbing their eye while their head and arms were inside the MRI, which is, you know, quite an amazing thing. And they produced not just a still shot, but a video loop. And the trauma and the movement of the cornea with that eye rubbing was insane. It was almost reversing curves of the cornea, and the iris was impacted and the retina was impacted and the vitreous was impacted inside the eye. And we often talk about eye rubbing being a common causative factor of retinal detachment. And when you see the amount of motion that occurs in an eye rubbing in an MRI video, you can understand how that absolutely could be. But it's the chronicity of it. If doing that on a regular basis changes the structural bonds in the cornea and causes a loss of structure and a loss of form and effectively stretching, you know, and that's where we get our corneas going from this lovely perfect curve to one that's more conical or one that's more pointed, which because it's stretching at a thin point. And probably the best way to think about that is anyone that's had a car tire or a bike tire that's got a weak spot, and it might get a little herniation at the side where it's thinner and it bulges. Well, that's pretty much what your cornea is doing. A herniation or a stretching towards a herniation anyway.
So just to get this clear, so keratoconus is a sort of outward bulging of the cornea caused by thin corneal tissue. Is that right?
Yes, it's again, it's similar to dry eye. It's a multifactorial disease. So you've got to have a few things, you know, in your camp to cause you to develop keratoconus. So not everyone that rubs their eyes will get keratoconus. But if you've got the right history and the right genes, then eye rubbing is going to make things worse.
Right.
And certainly it's one of the major modifiable risk factors that we've got. If we can get people not to rub their eyes, we can slow down or stop progression.
All right. Well, now that we have a basic understanding of what it is, I'm curious to get your take on how prevalent keratoconus is in the general population and whether you've seen any change in the incidence of it being reported, because I've talked to a few different people and I get some very different answers about how common it is out there. So I'd like to hear what you have to say about that.
The current official stance on this is it's about 1%. So 1 in 100 people in Australia will have keratoconus or currently have keratoconus. There are some studies showing that that prevalence is higher. So it's about 1 in 87 in Tasmania in particular. So we've got, in a study that hasn't really been published yet, but I've seen some data on it, we've got one of the highest incidence of keratoconus in the world.
Why is that? Sorry. Why do you think?
Well, that's to do with genetic cortical concentration because we're a smaller community and we're an island community. the incidence of all these inherited conditions is higher. So we've got higher
Mhm.
rates of glaucoma in Tasmania, we've got higher rates of MS, we've got higher rates of keratoconus, we've got higher rates of all these things, including a really weird one is colour vision in girls,
Right.
because colour vision defects are really prevalent in male children, but they're really rare in female children. But in Tasmania, the rates of female colour blindness is the highest in the world. So again, this particular geographic state that we've got is a very interesting mix for if you're looking for genetic links, and it's why there are such big research institutes like the Menzies Research Institute and the Save Sight glaucoma research groups are based in Tasmania.
So you said it's about 1% is the current thinking,
That,
and
that
has
that's a currently official numbers, yeah. So
okay, and
and that's been
has
that's
that changed over time?
no, but I think what we're finding is because we're able to find it more because there's more prevalence of and more incidence of mapping and technology,
Right.
we're confirming these numbers. So if they look at the if we go back far enough and we just look at the people that were referred for keratoconus, it was a much smaller group because most people with keratoconus were being handled with general optometry terms and they weren't being
Mm.
referred up the chain to ophthalmology. Now that we're getting a more confirmed diagnoses with the equipment that we've got in practice, we're getting a more real representation. So I'm not sure it's increasing apart from in Tassie, but I think that the confirmation of diagnosis is happening earlier in the stage in the progression of the disease, and often in the points of being teenagers and the 20-somethings that we're finding these keratoconus diagnoses.
Maybe that's a good segue to my next question is what tools or assessment techniques do you use at Martin's Eye Care to diagnose keratoconus accurately?
The two things that we use mostly, apart from our physical exam and looking at the eyes and assessing the likelihood of a vision correction or a vision refraction being suspicious, is corneal topography, so the ability to map the cornea. So the keratograph, the same machine that I use, that has got a big dry eye suite that allows us to look at the tear film in great detail. One of its basic functions is topography. So, at least it's placido disc sort of concentric rings, very similar to my shirt that's on today. And those rings get projected onto the cornea, and then the image of reflection of those rings off the cornea is assessed, and then we get an interpretation of what shape that cornea is. Is it perfectly circular? Is it astigmatically squashed? Is it distorted in an ectatic way, which is what keratoconus is, where we've got a distortion in one particular point. The second major bit of technology we've got is OCT, which is a special type of scanning tool. And if we normally use that to look at macular degeneration, and we look at it to look for glaucoma and signs of change in the retina. But if you use an anterior eye module, which we do have, then it's able to look for thinning of the cornea. And if I'm suspicious about someone having had hydrops, which is a distortion of the cornea after a significant stretching event with keratoconus, or if I'm worried someone's keratoconus is progressing, we can not only do corneal topography, but we can do anterior OCT, where we look at the cross-sectional plane of a slice in the cornea going through that distorted area and can measure the thickness of it. And if we see that in 2020 and we do another scan in 22 and another scan in 24, and we're seeing a change in that central thickness, we know that there's thinning occurring, which is more guaranteed. If you compare that to what the ophthalmologists have got, they've got the same sort of gear, but they've got a thing most commonly called a pentacam. And a pentacam is made by the same company, Oculus, that makes my keratograph. And the keratograph is really optometry centered, I guess, technology and modules, whereas the pentacam is, historical terms, has been centered in ophthalmology. So it's got anterior eye assessment, posterior cornea assessment, it's got anterior chamber and the whole depth of the eye assessment, all of that rolled into one. So it gives a whole heap of data. Some of the new modules that are coming in the pentacam are scleral lens fitting modules, which are designed and look at the scans going a little bit wider to look at the scleral landing zone. And we can use those to liaise with contact lens companies about fitting specialty contact lenses. So on my wish list of what I would love to buy, I'd love to go and buy a pentacam, but we're talking about $135,000, I think, for an optometry centered software equipment package, so it's getting up there in terms of dollars.
Yeah.
Compare that to my keratograph, which is like 35,000. There's 100K difference between the two.
Keep buying those lottery tickets.
Oh, mate, yeah, for sure.
So who is like at risk? Like where is there the largest risk profile for keratoconus? Like from what I
Oh,
understand, like things such as myopia are it's an issue for kids when their eyes are developing. And things like cataracts and, macular degeneration, that's, of course, a concern for older patients. But it seems to me that keratoconus is a kind of like special case because of the age demographic that you where it becomes like well, when most of the damage occurs, I guess. Is that right?
Okay. Sort of, yeah. Keratoconus is wacky because it's actually an autosomal dominant inheritance path, which means it should be very strong with its representation, but it has incomplete penetrance, which means it doesn't show up in the same way that an autosomal dominant disease would. And that again comes back to its multifactorial approach. So you've got to have all of the special herbs and spices in your environment and in your history, as well as that genetic profile to put you at risk of keratoconus. So some of the risk factors for developing it are things like a family history. So if we've got a family history, that's your inheritance link, isn't it? We've got a history of atopy or allergy. So if you've got a reactionary system or a reactionary eye, then actually you're going to be more at risk because you're going to be more likely to be eye rubbing and so on and so forth. People with connective tissue disorders, because the cornea is a connective tissue structure. So anything that is a disorder that might affect your connective tissue could have an impact on the cornea as well. Eye rubbing that we've talked about extensively already so far in this interview. Down syndrome's another link. So if we're talking about Down syndrome kids, it's a very high penetration of keratoconus with their eyes as well, and slightly higher in Asian and Arabian ethnicities as well. So if we start having patients that are from Iran or Iraq or what have you, then the incidence is a little higher, same as people from Vietnam or Korea or Japan or China as well.
Mm.
And I've seen new onset confirmed diagnoses of keratoconus in people pre-10. So we're talking under the age
Really?
of 10. I've seen advanced keratoconus at age 13, where it's suffered severe vision loss in one eye. And these are picked up for the first time at these ages when I'm seeing them. But the common age for things is the highest incidences, but is in your 20s and 30s. So it's a younger age type thing. So although we see it in exceptions in children and teenagers, the major link is probably 20s or 30 somethings. And I guess if you think about when do we try and recommend people have their eyes tested, we recommend there should be an eye test, before the start of school, so before the age of 5, which is not going to find keratoconus. We also recommend regular checkups through school, which may or may not find keratoconus. When we should be looking for this the most is when people in their 20s and 30s, which is often the stage where if people don't have a vision problem, they don't get regular checkups. They stop and wait until they get to their 40s and they're getting presbyopic and losing the close vision before they come back to the optometrist. So I've had a whole heap of new patients coming into the practice just recently, all in their, my age, so 40 to 50, all coming in, haven't had a checkup since school. So, so in one way that's pretty good, because if they haven't had a checkup since school, then they haven't had a vision distortion or a problem with their sight that's caused them distress. But other people have said, yeah, they've had vision distortions and problems with their vision, but they just sort of live life and they haven't still gone and got it looked at. So again, it comes back to regular checkups are still sensible. And if you've got even an inkling that something's not quite right, then you should be getting checked.
So if you're from one of those high risk demographic groups that you talked
Yep.
about, or ethnicities, or the backgrounds that you talked about, if you've got let's say a family history of keratoconus, when would be a good age to start getting regular keratoconus checks, if that's the case?
From the end of your teenage years and onwards, I would think is probably the most pertinent. Even if the diagnosis is in your 20s, there's going to be signs that mapping and other investigations in your late teens. And I
Well,
think because it's a multifactorial disease, the more of those risk factors that you've got,
mhm.
the more reason for you to come and have an earlier checkup.
Right, right.
So if you're Asian and you've got Down syndrome,
Mhm.
and you've got a connective tissue disorder
Mhm.
and you've got allergies of your eyes, you should be getting your eyes examined and double checking that you don't have keratoconus for sure.
Or if you're Tasmanian.
Or Tasmanian as well. And if you're Tasmanian, you've got a bit of allergy and
Yes.
all those things. So all these things are worth getting a
Yeah.
checkup. And occasionally I'll get someone that's cognizant enough and they've read something about this or they've heard something about this and they come and ask for a keratoconus review.
Yeah.
And I say, oh, why is that? Because it's not a common thing that people ask for. And sometimes it's because, oh, my dad's got keratoconus. I've got some allergies, and that's the reason, I'm doing it to keep my father happy. But
Yeah.
so, or my mother happy or something like that. But yeah, so it's anything that's a variety of risks, then it's a higher reason for you to get, a checkup. Even if you think things are fine, it's nice to have a screening.
Interesting. Okay.
And because it's considered a progressive disorder, sometimes having a regular screening is great because it gives us a baseline.
Of course, yeah.
Even if the thing is normal, we've got a baseline, which means in
Mm,
2025, when we've done the scan, it wasn't there.
mhm,
And you come back in and there's a little bit of a change in 2 years' time. It has
mm,
appeared within those 2 years, so we
mm,
know it's
mm.
starting now.
And of course, it's
Never,
always
never too early to have a baseline. Yeah.
never too early. And of course, that sort of presupposes that your optometrist has got the right sort of diagnostic equipment
Yeah.
to take a good baseline, right? Mm.
Or the right assessment that you go there, and if they're a bit suspicious, that they'll refer on, because most of the ophthalmology clinics, and certainly myself as well,
Yeah,
will take referrals of patients just to do scans, just to look for
yeah.
keratoconus. And then we do a scan, give the patient a copy of the scan, and we send them back to their optometrist. And the same thing happens at ophthalmology. So, and I do the same thing if I'm looking for something that I'm a bit suspicious of that's in the posterior cornea, because I can't assess that in great detail. I'll refer to the local ophthalmology practices just for a pentacam scan, and they'll accept that as just a scan, and they don't do a whole consult. There's not a massive fee. There's just a fee for the scan. And then the results come back to me. And if I do that liaising with, say, a corneal specialist, then they'll have a run their eye over it as well and give me a heads up whether they think there's something suspicious in it or not.
Interesting. Okay.
So it means a better cost triage system.
So if you're watching and you found this content helpful so far, then please hit the YouTube like button because it assists us with the algorithm and increases the opportunity for other people to benefit from Martin's insights. All right, well, so we talked about what keratoconus is and the diagnostics of it and risk factors. So I guess it's time to talk about treatment. So let's talk about some non-surgical treatment options for keratoconus. What options do I have available? I'm assuming that scleral contact lenses are part of the mix there.
Yeah, a lot of the time people come to me saying, look, I think I've got keratoconus, so I need this. And when you have a look at them, their vision is clear. You can refract them really well, which means just doing a normal eye examination with a refractor head or a phoropter. You can get them to the 20/20 vision, bottom line chart, just with a normal lens. Then they don't need contact lenses. They need monitoring. They need scanning. They may or may not need a referral for corneal cross-linking, which is a way of treating the cornea to stabilize it so it doesn't progress. And we can talk about that shortly. But that's all the important stuff at that stage. And maybe a pair of glasses is the most important thing because it gives you better vision than your own unaided sight. And it's not bad enough or distorted enough to require something more specific. I can't tell you the number of keratoconus patients that I fit with glasses and soft contact lenses, which normally you wouldn't say would be a thing for keratoconus. But if it's early stage keratoconus, if it's monocular and their vision is still pretty good, then we do the minimum that we need to. We don't need to go to the high level stuff.
No.
If it's a more advanced keratoconus or a more distorted cornea, then soft contact lenses don't give the vision that we require, or glasses don't give the vision that we want. And then we can do fitting with small or medium size RGPs or rigid gas permeable lenses, smaller lenses. And then there are larger size corneal lenses as well, which are slightly better and slightly more stable, often with keratoconus. And then we've got larger size, like scleral contact lenses as well, which are designed to dome completely over and mask the entirety of the distorted cornea.
Mm,
And we often think of scleral lenses as being the tool that we go to when the stuff's hit the fan and everything's bad and nothing's
mm,
good.
mm.
That's the thing that we go to, but it can be used at any time. It's just a different style of fitting. For some people, they have trouble putting the more hard lenses in and out. They struggle with that, or they don't like. They'd have trouble with comfort, or they might have an allergy type situation. They might have atopy and they've got really allergic eyes, and sometimes just fitting a normal smaller RGP lens doesn't work for that patient because they've got too many reactions and things. Whereas a scleral lens is often limits that and reduces the allergy response. So it can be a one that'll not only treat the vision and treat the eye, but also prevent the irritation of the eyes as well, or at least reduce it, not prevent it, but manage it in a better way.
And from what I hear, like fitting people with scleral lenses can be a little challenging. Like every fitting has to be sort of customized, and then
Yeah.
there's a whole like training and education process for patients on how to use and take care of those scleral lenses. Is this something that you deal with a lot?
Yeah, absolutely. And I don't think it's not dramatically different to the care and maintenance and the insertion and training procedures that we do for soft contact lenses or corneal hard contact lenses either. It is what it is. You know, there's a process of how do you
Mm,
insert this lens safely? How do you remove this lens safely? How do you look after this lens? And that's the same no matter whether we're dealing with soft lenses, soft disposables that are throwaway, or soft repeat use lenses, or hard lenses that are corneal based, or larger scale scleral lenses. they all have their own process, and it's nothing that's bad. I guess the biggest issue is if we've got people with smaller aperture sizes, so smaller eyes. Scleral lenses are often quite large, so sometimes being skilled enough to be able to hold the eye wide enough open to put the scleral lens in can be a little challenging. But we had a young lady in the practice the other day that we've been trying to fit with scleral lenses, and there's a variety of reasons for this, and I can't really go into that from a privacy point of view. But she's had some issues going along the way, and we got her to put a contact lens in her eye successfully, and she could see with it, or Adam did this week. So, and she was very happy, shall we say? You could hear her from outside the consulting room. She was so happy. And
Satisfied
that
patient.
was lovely. Yeah, really happy with herself. And and because it's been such a long process, and we've tried getting some funding that has failed through various, support systems and things to try and help her with this. Yeah, it's I think that sums it up. I think we don't stop giving, we don't stop trying.
Yep.
We don't stop giving up. Even if it's a complicated process, it's a process, it's a journey, and we'll be there with you along the way.
So even sclerals then, so there is a kind of a range of sizes. Like I've heard
Yep.
some talk about mini sclerals. So I
Yeah.
don't know if that's an official term or
I
not, but I think that the size
yeah,
actually varies quite a bit, doesn't it?
it does vary within a range. The I think a mini scleral really is just a scleral. So that's anything that sits on the sclera is a scleral lens. What we tend to do is we tend to do these large size corneal lenses that are, I guess, would in my brain are almost like a semiscleral, but they don't sit on the sclera; they sit on the cornea. But they're a larger diameter, and we've got a special fitting kit of those as well, which we brought into the practice just recently, which is a new design that I didn't have as part of my repertoire. So there's a lot of different options, and sometimes that's determined by what the patient can cope with, and sometimes it's determined by what the cornea can cope with, and we also liaise with those scans and the maps that we take with the keratograph and the anterior ACT machine, and we liaise with the contact lens labs and say, look, this is what we're getting, this is what we're thinking, and they might come back saying, look, Martin or Adam, this is not going to work. We can't do that. So I think your best option is to either do option B or option C, and option C might be a scleral lens. So sometimes what we're hoping for, what we're aiming for just doesn't pan out. Other times they come back and say, no, I think that's really viable. We'll try that. And if that doesn't work, we'll go to option B. So there's always a backup plan, and by liaising with those contact lens advisors that they've got at the labs, these are people that make lenses for a living. So they're dealing not just with myself as a practitioner, they're dealing with people ordering RGP lenses from scans and other things at thousands and hundreds of practices around Australia, whether they be ophthalmology practices or optometry practices, because both places would fit RGPs and scleral lenses from time to time. So and that means that you've got this wealth of experience and wealth of knowledge that from those labs that they know what they can and can't do. The software of the scans and the raw data of the scans, we often export that to the labs as well with permission, and they insert that into their machines, and then they can put a virtual contact lens onto the eye, and then they can play with different things, very rapidly to try and get a better answer. Rather than us doing, 20 fits of someone, we might be able to do a single fit and a scan, and then do a variety of virtual fits to modify those lenses, and then get to the right lens of what we're after on the second attempt or on the third attempt.
So just to summarize then, so for mild cases of keratoconus, glasses might be totally fine.
Yep, glasses, soft contacts,
yep,
corneal lenses, or scleral lenses.
Okay. Newbie question, which is my role here, of course, is to ask all the newbie questions. Orthokeratology, not an option for people with keratoconus?
It's tricky. So with ortho-K, you're trying to change the shape of the cornea to get an effect. What are the risks with that with keratoconus? And the fact there are risks. Could we theoretically do ortho-K after someone's had corneal cross-linking to make the cornea more stable? And the answer is yes, maybe. But again, it's something that gives us always pause. We don't. The big mantra that an optometrist keeps in their back of their head is to do no harm. We often talk about that being a medical vow. There's no vow that an optometrist takes. We're very cautious practitioners. We're not trying to take high risks. We're not stretching the friendship with anything. We're being very cautious with all of our approach. Tried and tested approaches to everything from dry eye to everything else. And ortho K and keratoconus aren't the best of friends. And I think anything like that, that we had a question mark in our heads and we were thinking maybe this would be okay, maybe they've had cross-linking or maybe it's some old case, we would always co-manage that with an ophthalmologist, and in particular an ophthalmologist that's a corneal fellow, so a corneal specialist. And together we make the decision, no, or yeah, let's give it a go, but monitor very closely.
All right. Well, this phrase of corneal cross-linking has come up a few
Mm-hmm.
times so far. So let's talk about it. So what is corneal cross-linking, and how effective is it, and when would you recommend it as a solution?
Okay. In the past, we've had surgical type options to deal with keratoconus in extreme cases. So we're talking about corneal transplants. And that's what most people think of when they think of surgery interventions. And I guess corneal cross-linking is it surgery? It's a procedure. It's a surgical procedure, but it's not surgery per se. It's certainly not a transplant. And what they do is they basically douse a cornea with vitamin B12, and they douse it over a period of time so it gets absorbed into the cornea. And then they illuminate that cornea, that eye, with a level of ultraviolet light for a certain length of time. And these are all prescribed with the different protocols that are followed. And what that does is it creates internal cross-linking. So imagining that we've got reinforcing bonds being built all the way through the structures of the collagen fibers of the cornea. And it makes it much stronger, makes it less likely to distort or become conical or progress. So when should we be doing that? Any evidence of progression in your late teens or 20s or 30s, you want to be doing that as soon as possible. Because what does it prevent? It if it's early stage keratoconus with signs of progression and that stops the progression, then you don't progress to ever needing a corneal transplant. You stop the almost reduce to nil the chances of you needing surgical intervention. If that happens later and there's a much more advanced keratoconus, then the cross-linking can hold things at bay, and it may still lead to a transplant, but it theoretically is not going to get any worse over time.
Mm-hmm.
So my thought on that is, again, earlier checkups, earlier interventions, earlier diagnoses lead to earlier referrals for cross-linking, which is a first line of defence. If you speak to a couple of corneal fellows, they talk about cross-linking, meaning that they're not going to be doing transplants for most keratoconus patients going forward,
So
which is amazing.
and so just to be clear that the corneal cross-linking is a something that you'd go to an ophthalmologist for, not your local
Yeah,
optometrist.
no,
No.
definitely.
Yeah.
So it's something that you'd go to your optometrist to see if that would be something suitable for you. And then with that, you'd get an answer yes or no, and you'd be referred to a local specialist to talk about doing the cross-linking.
Right.
I tend to use corneal surgeons to do cross-linking for most of my patients, but there are a number of ophthalmologists that are not particularly corneal surgeons that are doing cross-linking in Hobart. And I think you'll find that all over Australia. But my preference is always to deal with someone that specialises in the cornea. That's the person I want doing the cross-linking, because they're the ones that are going to deal with any aftermath of something going, not to plan or anything else of that sort of nature. So
And also, correct me if I'm wrong here, but if somebody like is in a situation where they do need a cornea transplant, that cornea isn't necessarily going to see them out for the rest of their life, is it? They may have to like come back for another transplant in the future. What's the
they
situation
can
there?
they can do, yeah. With something like a keratoconus transplant, if it lasts for so many years and they have to do another one, they can do.
Yeah.
Whereas if you've got a degenerative condition that's an infection or something nasty or then those people, they may not survive a second transplant. So
Mm,
so it's a bit tricky. But I've got some data for you on that too, if you like. So
sure.
this is some recent data that's been released as well. 98% of grafts for keratoconus are likely to survive the first year. So that does mean there's a 1 or 2% chance of a graft not working straight away, within the first year. 3/4 of grafts survive between 5 and 15 years, still maintain better than 612 vision. 612 vision is the legal to drive requirement.
Mm,
So
mm.
we're talking about 15% 75% of eyes maintain that vision between 5 and 15 years,
Right.
which is pretty reasonable.
Yeah, it's pretty good odds.
And the other thing to remember is the majority of people that have grafts will still wear glasses or contact lenses.
Right.
And a graft, there are special types of contact lenses that are post-graft contact lenses, like reverse geometry, are hard corneal lenses that I used to fit extensively in Queensland, and they're designed in a certain way to fit over an unusual cornea, like a grafted cornea. But that's also where scleral lenses come into their own. So scleral lenses are a great way to get the best vision possible from a grafted eye.
Well, as usual, this has been very informative, enlightening, insightful. Thanks very much, Martin. Before we wrap up, is there anything else that you wanna add?
No, I think I'll add one more thing. I think, which is the other thing, which is really interesting, because the cornea is an avascular organ. It's non-vascular per se. It doesn't require blood matching. So when you put on your driver's license that you're going to be an organ donor, it's particularly helpful to say yes to being a corneal donor, because corneal donors, if you donate your cornea, anybody that needs it can take your cornea.
Okay.
So it's a bit different to if you donate your heart or some other organ, then you've got to match your blood type, which means that your pool of people that could take your organ is very narrow. Whereas corneal transplants are really very, very broad. So anyone that donates a cornea, their cornea will be used. And I think that's a really interesting statistic to realise, is that corneas are really good things to say yes to donation. And if I could encourage everybody to say yes if they ever get an option to tick a box, tick yes to being a cornea donor.
Yep, can really make a difference to a lot of other people, can't it?
Absolutely, yeah.
All right. Well, so how can people get in contact with you and your practice?
Okay, our practice has got a Martin's Eye Care Facebook page. We've got an Instagram page as well. We've got our Martin's Eye Care website. We've also got our physical shop location, which is Shop 1 359 Main Road in Glenorchy in Tasmania. And we're available by email. And if you've got a Hot Docs account, you can refer yourself and find an appointment to us through Hot Docs. And other practitioners that are currently looking for you can refer you to us using the Oculo platform, which is an encrypted interprofessional file or referral system. So there's lots of ways, and our phone numbers 03 6272 8423.
And once again, if you're watching this and you found this content valuable, don't forget to hit the like button and also hit the subscribe bell if you'd like to be notified when Martin releases more highly valuable videos like this one. You should also follow Martin's Eye Care on Facebook and Instagram to stay up to date on the latest announcements, events, and promotions. All right, well, thanks a lot, Martin, and goodbye, everyone. Have a great day.
Thanks, Paul. See ya.
Bye. Bye for now.